Welcome back to the deep dive. Our mission here is, well, it's pretty simple. We take complex, cutting edge research, we slice away the jargon, and we give you what you need to know straight from the source. Today, we're getting into a medical paradox that is, it's right at the sharpest edge of modern medicine. We're focusing on solid organ transplant recipients, SOTRs, who get advanced cancer. And just, think about that dilemma for a second. Over the last decade, the biggest revolution in cancer care has been immune checkpoint inhibitors, ICIs. They're incredible drugs. They basically take the brakes off the immune system so your T cells can hunt down and kill tumors. That's the good news. But the brutal conflict, is that if you're a transplant recipient, you are on powerful drugs every single day to suppress your immune system. So the best cancer treatment wants your immune system revved up, but your survival depends on keeping it quiet.
It's a true medical catch-22. Clinicians have been trying to navigate this for years, and a lot of it was based on gut feelings and small case reports. So our objective for this deep dive is to really break down a huge systematic review and meta-analysis. This wasn't just theory. They pooled individual data from 343 of these exact patients.
And that's the key, isn't it? We're finally moving beyond just anecdote. We need to see the aggregated data to figure out two things. First, how well do these drugs actually work against the cancer? And second, what is the real measurable risk of losing that transplanted organ?
Precisely. We're looking at efficacy versus safety, and maybe most importantly, what factors might tip the scales one way or the other. This research gives us a map where before we were really just guessing.
Okay, so let's set the stage. The scope of this source material, getting data on 343 individual patients treated with ICIs is a huge effort. This review synthesized information from 140 different studies running right up through June 2024. So this is as current as it gets.
It is. And when you look at the patients themselves, the demographics are pretty specific. We're talking mostly male recipients, about 77%. And the median age was 63.
And something that jumped out at me, almost 71% were kidney transplant recipients. That's a huge majority. Why so heavily weighted toward kidney patients?
Yeah, that's a great question. It's really a reflection of two things. First, kidney transplants are just the most common type of organ transplant worldwide. But also, the long-term immunosuppression that you need to maintain the graft, that itself significantly increases the risk for certain cancers, especially skin cancers. So it just makes sense that the largest group of transplant patients would also be the largest group facing this dilemma.
That makes perfect sense. The biggest group is also the highest risk group. And what about the actual treatment? What ICIs were they getting?
It was really dominated by one class of drug, the PD-1 inhibitors, programmed cell death protein 1 inhibitors. Almost three-quarters of the patients, about 73%, got this type of ICI. So it gives us a really clean signal for how that specific approach works here.
And to measure what happened, the researchers used some pretty hard metrics. The primary outcome was, well, it was chillingly simple. Time to cancer-related death.
You can't get more definitive than that, right?
Okay.
And for the secondary outcomes, they had to measure that dual risk you talked about.
Yeah.
So they tracked the time from starting the ICI until the first acute rejection event. On the other side, they measured the cancer response using RECIST 1.1 criteria.
Okay, so let's just clarify that. We hear the term RECIST a lot. For our listeners, what does meeting those criteria actually mean in practice?
It's the standard yardstick oncologists use. It basically means the patient had an objective response. So either the tumor measurably shrank, a partial response, or it disappeared completely, a complete response. It's the hard proof that the drug is physically working on the tumor.
Got it. Okay, that sets the stage perfectly. Now we have to look at the numbers and confront that central conflict. How well did they fight the cancer, and what was the cost to the transplant?
Let's start with the upside, the efficacy. When they looked at the overall objective response rate, they found that about 1 in 3 participants, so 31.6%, had a measurable response at 1 year. And, for advanced cancer in such a medically fragile group, that's not nothing. It shows these drugs can work.
There's a big but here, isn't there? The fatality rate tells a different story.
It does. Despite that response rate, the overall mortality was it was staggering. More than half of the patients, 52.8%, died from their cancer within 3 years of starting treatment.
Wow.
So even when the drug works, the cancer is so advanced and the patient is so vulnerable that the death rate is still incredibly high.
So getting a response doesn't always translate to long-term survival in this cohort. Now let's pivot. Let's look at the other side of that ledger. What was the price the organ paid for this?
This is where the cost becomes really, really clear. Acute rejection happened in 36.2% of participants at 1 year.
More than a third.
More than 1 in 3 patients experience their body turning against the very organ keeping them alive.
That is a colossal rate of complication. I mean, in a clinical setting, that level of risk changes the entire conversation about whether to even start the treatment.
And it often led to the worst-case scenario. Within that same year, 18.4%, so nearly 1 in 5, lost the graft completely.
Lost the organ.
Lost the organ. They needed to go back on dialysis or hope for another transplant if they were even stable enough for it.
So let's connect those dots. You've got roughly a 1 in 3 chance the drug works, but that comes with a nearly 1 in 5 chance of losing your life-sustaining organ. The conflict isn't just theoretical, it's right there in the numbers.
Exactly. It confirms what doctors feared. You can't just take the success of ICIs in the general population and expect it to work the same here without some, devastating collateral damage.
But here's where it gets more nuanced and I think more interesting. The risk and the reward aren't the same for everyone. The data shows huge differences based on what kind of cancer they were fighting.
Absolutely. This is a critical finding. Some tumors are just far more responsive to this kind of attack. When you break down the objective response rates by cancer type, the difference is it's night and day. Patients with cutaneous squamous cell carcinoma, CSCC, which is a skin cancer very common in transplant patients, they had the highest response rate by a mile, 61%.
61%, that is a massive signal. That's double the overall average you just gave us. So for that cancer, the trade-off starts to look a lot more favorable.
That's the key takeaway, exactly. The next highest was melanoma at about 48.5%. Still very respectable. But then you look at the big group at all other solid organ cancers, things like lung, colon, breast cancer, and the response rate just plummets, down to 26.9%.
So the type of cancer you have basically dictates whether the ICI is a good bet or a really, really bad one. And the study actually quantified how much worse the outcomes were for those other cancers.
They did. They used what are called hazard ratios, which tell us the relative risk of dying from cancer compared to that best-case CSCC group. For patients with melanoma, the rate of cancer-related death was more than double, a hazard ratio of 2.29.
Double the mortality risk.
And for that other solid organ cancers group, it was even worse, a hazard ratio of 2.84. So for those patients, the data suggests the benefit is very small compared to the extremely high mortality risk.
What's really fascinating and frankly terrifying is that the cancer type doesn't just predict if the drug will work. It also seems to predict the risk to the transplant itself.
That's right. The study found that melanoma patients who had a decent cancer response but high mortality also had a significantly higher risk of acute rejection. Their hazard ratio for rejection was 2.88 compared to the CSCC group.
That's an incredible finding. It suggests that whatever immune activation is needed to fight melanoma is also inherently more likely to trigger that attack on the graft.
Yes. It's like a double whammy for them. The risk goes up on both sides of the equation. It really moves the clinical decision from a general one to a highly personalized one. The cancer type has to be the first thing you consider.
Okay, so if the data is basically screaming that the risks are high and that rejection is a huge problem, the next logical question is there anything we can do about it? Can we, build some kind of protective wall around the graft while still letting the ICI fight the cancer?
That was the crucial next step for the researchers. They looked for factors that could improve outcomes, especially focusing on the immunosuppressive drugs patients were already taking. And they found one combination that offered a real glimmer of hope.
Tell us about that. What was the specific cocktail that seemed to work?
It was the concurrent use of steroids and a specific class of drugs called mTOR inhibitors, mammalian target of rapamycin inhibitors, while the patient was getting ICI treatment.
Okay, so mTOR inhibitors. Most transplant patients are on some kind of maintenance therapy. What's special about mTORs that makes them potentially protective here?
Well, the simple version is that mTORs, like sirolimus or everolimus, are powerful immunosuppressants, but they work through a different pathway than the more common drugs. And critically, some evidence suggests mTORs might have some anti-tumor properties themselves, and they may regulate T cells in a way that specifically dampens the pathways involved in acute rejection. So they sort of help stabilize the immune system just when the ICI is trying to sound all the alarms.
So you're adding a second line of defense that might be both fighting the cancer and protecting the organ. Did it actually work? Did it lower the rejection risk?
It really did, quantifiably. The combination of mTORs and steroids was associated with a significantly lower risk of rejection compared to all the other drug regimens. The hazard ratio was a remarkable 0.30
0.30. So you're talking about cutting the risk of rejection by 70%.
by 70%.
That's not just a small change. That's a dramatic reduction. That might be the most actionable takeaway from this entire study.
I think it is. It suggests that if you have to use an ICI, then proactively changing the immunosuppression to include mTORs and steroids could drastically improve the odds of saving the organ.
So this is what it all comes down to. The cancer outcomes vary wildly by tumor type, with CSCC being the best case scenario.
Exactly. And most importantly, this specific drug combination offers a concrete, evidence-based strategy to try and manage that catastrophic risk of rejection.
So what does this all mean for you, whether you're a clinician or a patient trying to make this choice? This study confirms the danger, but it doesn't slam the door shut. For patients with these highly responsive tumors, like CSCC, the benefit might actually outweigh the risk, especially now that we have this potential protective strategy.
It really pushes the field forward by forcing two specialties, oncology and transplant medicine, to work together. You can't just treat the cancer in a vacuum. You have to actively manage the transplant risk at the same time.
So our final provocative thought for you to chew on really builds right from that. Given that most of these patients were older, mostly kidney recipients, and we still saw that nearly 1 in 5 graft loss rate, what's next? We really need studies to find out if standardizing this protective combo of mTORs and steroids in the highest risk groups, like the melanoma patients, could actually lead to a significant measurable improvement in graft survival over time. This research shows us that winning the cancer battle is completely inseparable from a calculated, proactive management of the transplant itself. You just can't have one without the other. Thanks for diving deep with us.